So welcome again, welcome everyone to the fourth PharmaCross webinar. At PharmaCross, we're committed to supporting the practicing veterinarians maintain and enhance their knowledge and skills and keep pace with the current standards in the field of veterinary medicine. This is the reason we decided to launch the PharmaCross webinar series. Today, we have the honor and pleasure to have Dr. Carla Dedola as our invited speaker. Dr. Dedola graduated in veterinary medicine from the University of Sassari in Italy in 2001. After her graduation, she started working as a general practitioner in a private veterinary clinic in Monza, starting to develop a passion in small animal dermatology. In 2007, she obtained a position as resident in dermatology at the Royal School of Veterinary Studies at the University of Edinburgh in Scotland. In 2010, she became a European diplomate in veterinary dermatology. She has been the secretary of the Italian Society of Small Animal Dermatology in Italy from 2014 until 2019. From 2011, she works as a freelancer in Sardinia, collaborating with many veterinary clinics in the district. She is the director and the scientific mentor for dermatological courses organized by SCIVAC, the Italian Scientific Society of Veterinary Medicine for Small Animals. Without further ado, I would like to invite Dr. Dedola to start her lecture. Dr. Dedola, the stage is yours.
Well, thank you very much. Thank you very much for the nice presentation and for inviting me. I'm very happy to be with you today, and I hope you're going to be happy as well now and at the end of the presentation. I'm going to share with you some of the knowledge we have about the approach to pruritus, and we are going to see how don't feel lost when you see an itchy dog. There are few tips that I'm gonna try to give you, and an approach that should always be systematic, a certain approach that will make things easier, and we will help you in the management of the pruritus in the dog. I'm gonna try to do this following a clinical case, because I thought that a practical approach would have been much easier to be followed, and we will see together all the steps that will bring us to the final diagnosis of the patient. So what we will be discussing, which disease we should rule out before we make a diagnosis of atopic dermatitis, and how can we rule out those diseases, which is nowadays the best therapeutic management for atopic patients. We are going to discuss a little bit about that. There's not much time, so I'm going to give you some information about the more modern therapeutic approach of atopic dermatitis. During the presentation, there are going to be some slides with the symbol, the exclamation mark, where I'm going to give you some of the fundamental rules I think are very important and not to be missed when you're following an approach to a final diagnosis in a pruritic patient. What I would like to tell you is that I'm not going to cover discussion about allergen specific immunotherapy and allergy tests, because otherwise the argument would have been really too long. But I'm happy to answer questions about this argument if you have any at the end of the webinar. So let's go now through the presentation. What is it, pruritus? The definition of pruritus is very old and is unchanged since the since 1950 since the 1066, and is an unpleasant sensation that provokes the urge to scratch. is not a bad thing, because like pain is something that allow us to defend our body against potential harmful agents like the sting of an insect or the irritating contact with an irritation substances. But when these become chronic, it starts a vicious cycle that can become pathologic, and it becomes self-perpetuating. So this is the classical itchy scratch cycle that it happens to see on our patient when we visit a dog that has got a chronic itch. So we have itch, the dog starts to scratch. By scratching, especially when it does in a chronic way, it's going to damage the skin barrier, which allows more penetration of allergen and irritants. This will increase the inflammation of the skin and provoke more itch. So the majority of cases that we see has got lesion on the skin provoked by itself scratching and not by the disease itself. So to stop this cycle is very important in order to succeed in the cure of this patient, in the management of this patient. What are the most common cause of pruritus in dog? The first things that you have to thought about when you have especially a relapsing pruritus in a dog are allergic dermatitis. Allergy in dogs can be directed towards flea bites, food, or environmental allergy. That is what we call canine atopic dermatitis. There are also commonly some ectoparasites that can cause pruritus itself. They cause pruritus because they start a sort of allergic reaction, but they are not together. They are not put together with the allergy, and those are the sarcoptic mange and the autodactic mange. Much less commonly, other disease can cause pruritus, such as a very common disease that is demodicosis, that is actually usually not pruritic, but that in some occasion, especially when we have secondary infection, and we will see that, it can cause pruritus as well. Leishmaniosis is another disease that can cause pruritus a bit more often than other disease, and occasionally dermatophytosis can be an itchy disease. Of course, every skin disease can become pruritic at a certain point, even if it's not pruritic as a primary condition. And this usually happens when we have the development of secondary infection, usually caused by bacteria. The most common bacteria involved in skin bacterial infection is the Staphylococcus pseudointermedius, or yeast, the very well-known Malassezia. Those secondary infections can actually aggravate a pre-existing pruritus, as happens, for example, in a course of allergic dermatitis. Dog is itchy because of the allergy, but is much more itchy. The itchiness is much more severe if the allergy is complicated with secondary infection. Or can cause pruritus, as I was telling you before, in non-pruritic disease. An example is an hypothyroid patient that is usually not itchy, that starts to scratch because it develops a secondary Malassezia dermatitis or bacterial infection. And this can cause us a bit of confusion, but we have to learn, and we will see something in this presentation, to recognize and to diagnose those secondary infections. So let's start now with the case we are going to present. So this is Asia, is a 3-year-old female nutria Dachshund. The owner complained, so the reason why the owner brought Asia to us is because she referred the presence of pruritus and what she called dandruff, which is typical for owner to call an exfoliative dermatitis on the head, that has been noticed approximately 3 months before. The referring vet has given a therapeutic course of systemic antibiotics with amoxicillin clavulanic acid with no improvement. In the past, Asia, talking about her previous history, has suffered of other episodes of pruritus that has been treated both with antibiotics alone or antibiotics and glucocorticoids with variable success. So we have an information about this dog that has suffered about episode of pruritus in the past. And this is an important information that you have to ask when you're taking the history of the patient. Other important information that are part of Asia history is that Asia lives in an apartment with no other animal, so she's the only dog. She's regularly vaccinated and she's treated for ectoparasite with a spot-on product containing permethrin and imidacloprid monthly. She is fed with a good commercial dry dog food, and the owner reported to us that she seems otherwise in perfect general health. She's happy, she's hungry, she does, you know, she lives a normal life otherwise, apart from the scratching. We go ahead in our general physical examination where we cannot detect abnormalities at all. And now I'm going to show you what we are going to find on the examination of the skin. So as you can see, the head, as reported from the owner, is interested in this dog from both sides, so it's bilaterally involved. We can see alopecia, those scales reported from the owner that are localized on the temporal region and on the periocular skin. If we go to have a closer view of the case, we can actually see there are also some small papules that are those small red raised dots on all the temporal region that you can also appreciate in this area with those scale, small white adherent scale on the skin. The dog has also lesion on the right ear in the ear pinna, always related to scale, so small white scale as you can see. The ear canal is erythematous and we have waxy cerumen coming out from the ear canal. So probably we are also facing an otitis externa in this patient. So if we have to do a list of problems of this dog, which is the list that you should do every time you see a dog that has got dermatological or other type of problem, we are gonna say that Asia has of course got pruritus. This is something we cannot appreciate on the clinical examination, but has been referred to the owner. We have an exfoliative dermatitis, which is the responsible for the presence of the white scale that was the dandruff referred from the owner. We have a papular dermatitis, which I show you in the picture, those small raised red dots. We have alopecia, which is absence of hairs where it usually should be. And we have a unilateral otitis in the right ear. Always remember to complete your problem list with the distribution of the lesion, which is very important in dermatology because it can give you some information more. And in this case, we have lesion distributed on the head, on the periocular region, and on the pinna. The problem list, when you see a clinical case, usually help you in list your number of differential diagnoses. So in this case, with this problem, we are gonna list a differential diagnosis, this list as follows. So the first things I thought about, it was that Asia could have been an allergic patient, allergic both to food, to environment, or maybe also to fleas. It is impossible to define which is the allergy, the allergen responsible for an allergy just looking at the dog. And we're gonna see this during the presentation. I thought this because this dog has got a problem in the past, recurrent problem, and recurrent pruritus is commonly seen in allergic patients. Another possibility is that Asia has been in contact with some ectoparasite, has been contagious with ectoparasite like Otodactyl cyanotis or Sarcoptes scabiei, or that she's suffering of demodetic mange. So she's got Demodex canis. That is, for example, pruritic, pruritic for presence of secondary infection. I live in a very in endemic area for leishmaniasis, so many times leishmaniasis is present in my differential diagnosis list. In this case, there are many reasons because I put these possibilities, and this is related to the type of lesion, which is an exfoliative dermatitis, very typical in canine leishmaniasis, and the localization. If you remember, this dog had a periocular distribution, which is quite often seen in course of leishmaniasis. And then another possibility is that we have a fungal infection. This is the last differential diagnosis. Differential diagnoses are always listed in order of probability. We can see a generalized dermatophytosis, as in this case. So we were going to see how we can rule out all these possibilities one by one. All of this disease can be, as we've talked before, complicated by secondary infection that can be either bacterial or from yeast. I cannot decide, this from the clinic presentation. I have to do diagnostic test. So what I would like you to think about is that today I'm talking about Asia. I'm presenting you Asia. But I could have presented Max, which is this, nice young bulldog that is scratching his axillary region. I could have presented Trilly, which is, a mixed breed dog that is scratching her muzzle and also her feet. Or I could have presented Luna, which is a dog suffering of a much more chronic situation, pruritus that is going on for much long time. But what I would like you to fix in your mind is that the diagnostic approach to those patients would not have been different. So every time you see a dog with a pruritus, you're gonna do exactly what we're gonna do this time. Do not think about other possibility just because Asia look in some way and all the other patients look in other way, because especially atopic dermatitis or allergic condition are very variable in their presentation. So concentrate on the pruritus and follow step by step what we are doing with Asia, whatever is the case you have in front of you. So this is one of the slides I told you. The rule number one that I really think is important: ectoparasite, Sarcoptes and flea especially, but as we have seen, also Demodex mites should be ruled out in any itchy patient, even when you have a dermatologic lesion that is not suggestive for them. So even if you cannot find any evidence of their presence, you should treat them in order to rule them out. Don't think that a dog cannot have a sarcoptic mange just because you don't find it in your skin spray. Don't think that a dog cannot suffer of a flea allergy just because you cannot see fleas or you cannot see flea dirt on the patient. So if you find them, good, you have your diagnosis, so you're gonna treat the dog for the disease. If you cannot find them, then you should treat it. And this is valid especially for Sarcoptes and for fleas, not for Demodex, that is very easily found on your skin scrape. Sarcoptic mange especially, just to go a little bit back in time when we were studying those diseases, is an intensely pruritic contagious skin disease caused by Sarcoptes scabiei. The lesion itself caused by the mange is a generalized papular erythema that initially involved the elbow, the hooks, and the ear pinna, but in more chronic case can be generalized, and the lesion, of course, are then showing what is the result of a chronic scratching, so self-induced excoriation and crust. The diagnosis of sarcoptic mange is done by the skin scraping, superficial skin scrape. but it's very difficult to demonstrate the presence of this mite or of its egg on the scrape. It happens sometimes also to me that I have to do up to 20 skin scrape before I can find the mite. So it is important that you consider this as a possibility in every itchy dog, and you treat the dog with a specific acaricida treatment as a part of your diagnostic procedure, even if you cannot find it. This is a very important thing. And those are just few pictures, just to show you how can a dog with sarcoptic mange look like. Not, in this case, very different from what we have seen in Asia with this periocular alopecia. Okay, this dog has got lesion also in other parts of the body, but it can happen to see dog just with lesion localized on the head and the ears. This is, for example, is not a very typical localization for sarcoptic mange, the paw and the distal part of the leg, but this dog had lesion just in the front paw and the hook and has got sarcoptic mange. So don't stop yourself just because the dog doesn't look exactly how is described in books. Regarding fleas, the concept is even more important. Usually, if you have a non-allergic patient, you can have non or very mild pruritus, even if this dog has got fleas. And this is very important when you have an owner that is questioning about the fact that his dog can have fleas because other dogs in the environment are not scratching, and this patient, yes. This is because the patient that you're seeing that he's itchy is actually allergic to flea bite. The other dog or cat maybe are not. So not all dogs with fleas are going to scratch. The dogs that are going to scratch are dogs that suffer of flea bite hypersensitivity, and they have pruritus associated with a papular dermatitis. And again, we have quite a typical distribution of this lesion in this case. That is the lumbosacral area, but also the neck and the abdomen. But you don't have to stop yourself at this concept, because there can be dog with flea allergy, with a generalized pruritus, or with lesion localized in other area. Again, if you can confirm your suspect of diagnosis, finding fleas or flea dirt in the dog, that's fine, well done. If you can't, you still have to treat it, and treat it regularly before you can say that this is not responsible for the pruritus in your dog. So again, treatment is part of the diagnostic approach. And those are, again, just few pictures of dog with a typical flea allergic dermatitis. Some, more mild case, so only a localized area where the dog is biting. This area often are characterized by the presence of a hot spot or acute moist dermatitis, which is, this localized lesion that can be present on the rump, but sometimes also on the neck. This is a little bit more chronic case, and this is definitely a very chronic case. All these dogs suffers about the same things. But also this dog had, perianal pruritus, and this erythematous papular dermatitis on the abdomen, and this dog is suffering of flea allergic dermatitis. Even if the rump itself is not affected, I just, cannot exclude that this is the problem. Even if I cannot find fleas, I cannot say that this is not a problem of this dog. So let's go back to our patient. So as we said, we have to rule out differential. And how we're going to do that? With a superficial and deep skin scrape, because we have mange that we want to see if they're present and they are negative. I can also take the opportunity of see if I can see some fungal spore or hyphae on the hair shaft, and the sample were negative. I can collect cytology, in this case by the aid of an acetate tape, because I didn't have moist area to sample by the only impression smears with the slide. So I use the acetate tape that has got the glue, so I can collect more sample in this way. And On the head and the temporal region, I found a lot of Malassezia, which are those organisms which has got this funny shape, peanut shape or footprint shape, and are in a high number. Malassezia is a commensal, we will see it later, but we cannot find so many on a cytology. We have to find just a few. If we find so many yeast on a skin of a dog, there is a problem. We do cytology of the ear canal, and we have a look to the fresh cerumen to see if I can see Otodectes or what is it present. I cannot see Otodectes, so it's negative for otodectic mange, but I can see Malassezia as well in the ear canal. I run a serology test for Leishmania antibodies that is negative, and I plan to do a fungal culture collecting hairs and scale to be processed. But this take a little bit of time. It can take up to 14 days. So at the moment, we don't know the result yet. So now we're gonna go through the question that you're going to answer, so that you take a little bit part to the presentation with me. So this is the question 1, and I'm gonna ask you, which of the following differential diagnoses can you rule out almost certainly at that point? So the answer are, I can rule out sarcoptic mange, I can rule out dermodicosis, I can rule out dermatophytosis, I can rule out leishmaniosis. So now we wait for you to answer. Just think a little bit what we discussed before. I hope you know the message has gone through, and let's see what you think. We can, quite confidently saying that is not responsible for Asia lesion, in view of the test, the result of the test that we have done. I can see that the majority of you are answering. We are still a few seconds left to complete the questionnaire. Okay, so the majority of you has answered leishmaniosis. Some of you has answered, and there's an equal distribution of the other answer. So unfortunately, the correct answer was dermodicosis, which, as I told you, is very easy to be found on skin scrape. So if you don't see Demodex, it's very, very difficult for it to be responsible of your skin disease. The same we cannot say for the other disease. Sarcoptes, as we said, can be present even if I don't find it on the skin scrape. Dermatophytosis, we've done the fungal culture, which is pending, which is the golden standard to diagnose a fungal infection. If you see dermatophyte hyphae and spore on cytology, fine, you have a diagnosis. If you don't see them, you cannot say that this is not the problem. For what concerns leishmaniosis, this is a very complex argument, but unfortunately, again, you cannot rule out certainly leishmaniosis just because you have negative serology, because there are dogs that has got the disease even in face of a negative serology result. Okay, let's go ahead. So at this point, as I told you, this was our original differential diagnosis list. So we can definitely rule out Otodectes. We haven't found, it's very difficult not to find it, and Demodex. The other disease, leishmaniosis, dermatophytosis, are less likely because the negative result, but as I told you, I cannot really rule them out completely from my list. They stay there. And once I'm going ahead in my diagnostic workup, I see whether I need to do more tests to confirm them or not. So, of course, we have a new data, which is that Asia has got a secondary Malassezia, otitis, and dermatitis. And we take this message home because it's important for the treatment. So, rule 2, in fact, secondary infection. As I told you at the beginning, bacteria or yeast can complicate a pre-existing dermatitis, and they often or actually have always result from an underlying skin disease. And the most common disease responsible for the development of secondary infections is actually atopic dermatitis. They can be easily diagnosed with a simple cytological investigation that can be done by impression smear with a slide if you have a moist lesion, or with the aid, as I've done in this case, of an acetate tape or with a swab. Then you stain this slide with this very quick, deep quick stain, very easily to be found, and you look the slide at the microscope. The majority of the infection that you're gonna diagnose, bacterial, Staphylococcus intermedius, or Malassezia pachydermatis, are commensal of the skin. So it's normal to find a few of them, but of course, if you find lots of bacteria, lots of yeast, and also often in the presence of inflammatory cell, then this is not a normal situation and you have to address it. So, as I told you before, they can cause pruritus itself, even in non-pruritic skin disease, so you have to treat them in order to succeed in the control of the pruritus in your patient. Just a few more images, just to remind you that this secondary infection can look very differently, and those are just for example of how can a superficial pyoderma look like. As you can see, all these clinical lesions are different one from the other. Here you have pustules, which is the typical lesion that we would expect to find when we have a superficial bacterial infection, but that actually hardly ever we are able to find because it's a very, very delicate lesion that is going to be broken by the scratching of the dog. So we usually found, actually, what we usually found in those patients are the lesion that we call epidermal collarettes, which are those round lesions surrounded by this scale or crust that is often in the center starting to heal, that are probably the result of the rupture of the pustule and the diffusion, centrifugally of the bacterial infection. Sometimes those collarettes coalesce with one with the other and they form this aspect. So this lesion can look completely different, but the responsible is always a bacteria. And if you do collect cytology, you will find more or less the same picture. And if you gave antibiotics or topical antiseptic, you will have success in treating those patients. This is how usually, but there are many, many possibilities, a superficial pyoderma cytology look like. Here we have all these lines are neutrophilic nuclear strain, but all what interested us especially are these black, violet, black purple dot, which is staphylococci. And here we have a little bit well-conserved neutrophil. Here we have a macrophages with all these dots, which are actually both intracytoplasmatic or extracytoplasmatic bacteria. So if you have a picture like the one I show you, and this is the cytology, you have your diagnosis of secondary superficial pyoderma. And those are, again, few examples on how Malassezia look like. It is often associated with this brown stain color, but that is not obligatory to be present. It's just suggestive. Sometimes the presentation can be similar to epidermal collarette, and this is a very chronic situation in which we have this black, thick skin, lichenification is called, that is often associated with Malassezia dermatitis, but you have to be careful and you always have to perform your cytology because the same clinical presentation can be associated with a condition called bacterial overgrowth. So this dog could have both Malassezia or bacteria. So in order to find out, you have to do your cytology with your acetate tape in this case, and those are the yeast. As you can see, there are many, many microorganisms wall to wall in this case, these footprints, as I told you, shape. In this case, we also have, as well as in superficial pyoderma, nuclear neutrophil strain, but in this case, we definitely have Malassezia and not bacteria. And this will change a lot your therapeutic approach. So it's important for you to assess whether the secondary infection is due to bacteria or to yeast. The third important rule that you have to think when you are starting or you are in the middle of a diagnostic workup in an epruretic dog is that you have to address the pruritus even during the diagnostic workup. In the past, maybe 10 or 15 years ago, not so long time ago, but even less probably, we were used to say that we were not going to do anything for the pruritus because otherwise we wouldn't have not understand what was going on with the dog. Now the approach has completely changed. While you are working to the diagnostic approach to know what is wrong with this dog that has pruritus, you take care of the pruritus as well. You don't have to leave the dog scratching just because you want to know what is working. And I will show you in this presentation that you will have the way to know which is what's wrong with the dog, even if you stop the pruritus. You have to remember that this will help also in the owner compliance, because the owner has brought you the dog because it's itchy and he doesn't want to have the dog scratching until you hand it up with your diagnostic workup to know what is wrong. He wants the dog to stop scratching in that moment, and then you go ahead and find out what was wrong. Also the stop of the pruritus will reduce the self-trauma and maybe will also be helpful in the coming out of some lesions that were not evident before when the dog was scratching a lot. So, as I told you, I'm gonna show you how I'm going to put in practice what I told you you should be doing. So, Asia, we have to rule out ectoparasite. We haven't found them on our scrape, but we still have the feeling that they can be responsible for the disease. So how can we do? We use a product against both acariciidal and insecticidal. In this case, I've used Sarolaner, but it could have been, any of the isoxazoline or any other product that is both efficacious on the fleas and on the Sarcoptes. Sarolaner is given per os once a month. I stop the pruritus, so I make Asia comfortable and the owner happy. And I gave, in this case, oclacitinib with the standard label dose of 0.5 milligram per kilogram twice a day for the first 14 days. And then if I have to continue the treatment, I will give it just once a day if the dog has stopped scratching. I'm going to take care of the secondary infection. In this case, I've used just topical product, topical ear drops containing miconazole, which is helpful in with the Malassezia, prednisolone for the pruritus, and Polymix B, which actually we didn't really need it because we didn't have bacterial infection, but unfortunately the majority of ear products contain these three product, so antibiotics, antifungal, and steroids, to be applied twice daily for 14 days in the ears and also on the skin around, and chlorhexidine 4% solution once a day locally. I gave also Asia an hypoallergenic diet with hydrolyzed protein that I told you the owner to leave it for a minimum of 8 to 12 weeks. Now, the food trial. This is another very important point. You can start the food trial for the discussion we were having before at the beginning of your diagnostic workup, as I've done, just to reduce the length. So I start everything together and then I'm gonna find out if the dog stopped scratching, what was the cause of the pruritus. I have the way of doing it. Or you can start it even later. So if you have, for example, a very high suspicion that a dog has got sarcoptic mange because of the clinical presentation is very, very, very similar to what you think a dog should look like with sarcoptic mange, then you can also wait. In this case, I've started it because I wasn't really convinced this dog has got sarcoptic mange and I want to reduce the length of my diagnostic approach. Which type of diet should I choose? You can choose a homemade diet or you can choose a commercial diet. The importance in the homemade diet is that it should be done with a novel protein or novel carbohydrate source, so something that the organism of the dog has never get in touch with, has never eaten. And the hydrolyzed protein, you know, are this protein that has got a very, very low molecular weight and cannot act as an allergen at all. The length of the diet should be minimum for 8 to 12 weeks, and the diagnosis is not reached if the dog improved on the diet, because the dog can improve for whatever other reason. In our case, it can have improved also because we gave the treatment for pruritus. We have to have the improvement of the diet, but we must have a relapse of the pruritus when we give back the food the dog was eating when he was scratching. This is a very, very important point. So in order to do diagnosis of food allergy, we have to have an improvement on diet, maybe also associated with the treatment for pruritus. But then after we stop the treatment for pruritus, we keep the dog on the diet. If the dog is still not scratching, we have to demonstrate that the dog starts scratching again on the previous food. This is very important. So this is our patient after 3 weeks. The owner referred, there's no pruritus at all. As you can see, Asia has come back to nearly normal and normal dash wounds. Finally, we have fungal culture result that is negative. And now I'm going to ask you the question number 2. So which of the following do you think can be considered the final diagnosis with Asia, also on base of what I told you? Asia has got a sarcoptic mange that has healed with the Sarolaner treatment I gave. Asia had a cutaneous adverse food reaction that has resolved with the hydrolyzed protein diet I gave her. Or Asia is atopic and she just improved because I gave her oclacitinib and she's going to relapse once I stop oclacitinib. Or do you think for us it's still not possible to know which is her final diagnosis, just because we don't have enough information? So what do you think we are at this stage? Again, many of you are answering, which is good. Just wait a few seconds more before we end the polling. Very good. Nearly all of you has answered. Come on, I think you know, you know this answer. I'm pretty sure you know it. So here we go. The majority of you has answered the answer number D, which is actually the right answer. We are still not able to know which is the final diagnosis with Asia, because as I told you, we've done the treatment for sarcoptic mange, we've done the diet, we've done the treatment of pruritus. So why Asia has improved? Let's go and see which is the reason altogether. So we are in this situation. Asia has got sarcoptic mange, food reaction, adverse cutaneous food reaction, or atopic dermatitis. How can I find this out? It's very, very easy. I just stop the oclacitinib and the topical treatment for malassezia otitis, and I keep her on Sarolaner every month and on hypoallergenic diet. I will make clear with the owner that I plan a recheck in 3-4 weeks time, but I make clear that with the owner that he would need to call me if things change or get worse. This is another important point. So rule 5, communication. This is one of the main reasons of unhappiness of people. People that doesn't know what is going to happen, that see their dog that is not scratching anymore, they are very happy, then we stop the treatment and the dog starts scratching again. This is absolutely normal if you have a dog, for example, with atopic dermatitis. So you have to be sure that yourself and the owner know that. So you will tell the owner, we are working to a diagnosis of a possible atopic dermatitis. Asia could have been sarcoptic mange or food intolerance. We don't know. In order to see what's wrong, we stop the treatment for pruritus. But please be careful about the fact that Asia can start scratching again. In fact, if Asia is an atopic patient, the disease will be for life. you know, we will have to control the disease for all Asia's life with the continuous management. We will never be able to cure it. And this is very important. And the other important message that you should make clear with the owner is that, yes, we are testing a food allergy. We gave Asia a food hypoallergenic diet, but the food might not be responsible for Asia problem. The majority of the owner that goes out of your surgery, of your clinic with the diet are convinced that their dog is scratching because of the food. But actually the food is one of the least responsible of the pruritus in dog. Atopic dermatitis, flea allergy, they are much more common. It's very, very unlikely or unusual to have a dog with food allergy. We have to test it because it is possible, but we have to make clear with the owner that maybe or most probably the problem won't be that. So the owner has to know that it's just a trial in order for him not to be upset when this happened. And in fact, Asia, 1 month later, despite the owner being very committed, giving Sarolaner monthly, feeding only hydrolyzed food, has started to be itchy again. The clinical presentation is a little bit different. So this time we have pruritus in both axillary region with all these papules. The pruritus around the eyes are starting again. And this time we have erythema of the left ear, not anymore of the right ear. The owner tells us, as often happens, that the pruritus has started few days after it stopped oclacitinib. But it was very mild. He thought, you know, he could wait, and this is what happened. So even if we've been clear, we told him to call us, this will happen many times, that they come to us a little bit later. But nothing is lost. We have the case here, the owner has come back, we can still bring the case to us and now decide what to do. Again, physical examination, because things can change. We visit our patient, nothing wrong. Asia is perfectly healthy, as we saw the first time. And now we go through dermatological examination. We saw this papular dermatitis on the axillary region. We saw this alopecia on the left temporal region and a unilateral otitis, this time on the left ears. Let's do cytology. Again, things can change. It's not necessary that because Asia has got malassezia the first time that she's got malassezia the second time. And in fact, this was the cytology of the papules. So what will I show you on the superficial pyoderma? Neutrophils and bacteria. And this is the cytology of the ear that again is a otitis caused by the overgrowth of malassezia. And now we are going through the third question. So now I'm gonna ask you, which of the following do you think can be considered the most probable final diagnosis for Asia? We have superficial pyoderma, we have an atopic dermatitis, we are facing a cutaneous adverse food reaction, or maybe we're gonna back in our diagnosis and Asia has got leishmaniosis and you know, we have to test it again. So the polyps to start, here we go. So concerning regarding what I told you before, let's see. I'm pretty sure that this time you're gonna get the right answer. So what's wrong with our patient? Do we finally know, or we are still, you know, not sure, or maybe we still have to work at it, as often happens with this dermatologic patient that we stay months and months thinking of what is wrong, or maybe it's easier and this time we got our diagnosis. So a few seconds more, the majority of you has answered. That's it, perfect. I'm very happy that nearly all of you has answered the right answer, which is atopic dermatitis. And this is really the most probable disease that is affecting our patient. So the disease was well controlled until we were doing the treatment for pruritus and for secondary infection. Once we stopped, despite the food, despite the treatment for ectoparasite, pruritus came back. The important thing is that the owner knew it and you knew it. Doesn't matter if the pruritus come back, now we know what's wrong with Asia. Superficial bioderma, it was present, of course, it's not wrong, but it cannot be a diagnosis. You cannot end up your diagnosis saying, oh, this dog has got superficial pyoderma. No, it's very important when you see a superficial pyoderma that you ask yourself why this dog has got superficial pyoderma. So this should be very, very clear in your mind. So now we are going towards, the end of this webinar. And yes, Asia is affected by atopic dermatitis. What is it? Canine atopic dermatitis is a chronic disease with a genetic predisposition. So there are some dogs which are prone to develop the atopic dermatitis, certain breed like Labradors, French Bulldog, Boxers, West Island White Terrier, all breeds that I'm pretty sure you know, and you've seen, surgery with that were very itchy. And it's a disease that predisposed the patient to develop a sensitization towards environmental allergen. The majority of time we are talking about pollens and house dust mites. This dog usually have high IgE directed towards those allergens. Those dogs has also got, as part of their genetic defect, a defect in the epidermal barrier. There are many, many parts of the epidermal barrier that are deficient in this dog, and this caused especially an increased allergen penetration through the skin that will just make atopic dermatitis worse, and also will get this patient prone to develop more easily secondary infection. The one that we saw, bacteria or yeast, are the most common. There are also environmental factors involved in the development of canine atopic dermatitis, like, the place where a dog lives, has grown up, where the mother of the puppies were grown up, the allergens on the environment with which the dog get in touch with. So also these are important and part of the development of the disease. The usual anatomical sites affected are the one that I'm going to show you. So the paws, axillary region, abdomen, and face, muzzle, head, ears. But obviously, as I told you, you can have dog also with generalized pruritus. The age of onset is very variable, can be from 6 months to 6 years. I cannot stop, a diagnosis of canine atopic dermatitis just because I have a dog that starts to be itchy at 10 years old. However, the majority of dogs develop clinical signs between 1 and 3 years old. As I told you, it's a chronic skin inflammation with pruritus and characterized often by the recurrence of skin infection. And this is another important point. Many dogs have got atopic dermatitis and show this disease just with the presence of recurrent pyoderma. So you have to think that this dog might have atopic dermatitis if you have some patient that comes with pyoderma coming out. The pruritus can be seasonal, especially if pollens are involved, can be non-seasonal, so all year long, or can be non-seasonal, but we can have a seasonal worsening. So a dog is itchy more or less all year. When it's spring or summer, the pruritus goes up and up. The diagnosis of atopic dermatitis is clinical and is done with the step we've seen with Asia. So you have to rule out other pruritic conditions before you can say that a dog has got atopic dermatitis. You cannot do diagnosis of atopic dermatitis by doing allergy tests. This is an important point. Allergy tests are just performed once you have your final diagnosis, and if you want to run an allergen-specific immunotherapy in order to control the disease. But it's not a diagnostic procedure. So you are the doctor, you are the clinician, you can do a diagnosis of atopic dermatitis. You don't need laboratory tests. The treatment is very variable because very variable is also the clinical manifestation, and there's not a single treatment or a universal treatment that can be given that will fix all atopic dog. There are at least 4 important steps in the therapeutic management that I'm pretty sure you've learned. The first is that you have to do ectoparasite prevention regularly and all year long, because usually dogs that has got atopic dermatitis are very often also allergic to fleas, so you don't want them to get fleas as well. You have to control the pruritus. You can have acute flares that you have to get under control, but most of the times you have chronic cases that you have to keep under control. So you have to keep them under medication or whatever you decide to do to keep the pruritus under control. Treat and prevent secondary infection endotitis with topical, if you can, which is better. With the antibiotic resistance, you have to try to avoid systemic antibiotics, or systemics if really the lesions are very extensive or the owner is not able to do topical treatment. And another very important point is that you have to take care of this defective skin barrier that I told you before. You have to restore it. So what can I do to control the pruritus in canine atopic dermatitis? There are 4 main treatments available. Glucocorticoids is an old treatment. They are efficacious. They are nowadays used very rarely because, as you all know, they have lots of side effects, but they can still be helpful both for systemic administration in very short period to keep under control acute flares, or as a topical treatment in the long-term management. Cyclosporin, again, is a very highly effective treatment with few side effects. Vomiting, diarrhea are the most common. Unfortunately, it's not as rapid as glucocorticoids in keeping under control, in get under control the acute flare. So it's mainly, when you decide to use it, it's mainly indicated for long-term management at the standard dosage of 5 milligrams per kilogram daily, that should be then reduced to the minimal effective dosage in order to control the pruritus of the patient in the long term. Then we can use oclacitinib. Oclacitinib is a JAK inhibitor. The JAK-STAT signaling is a signaling important to start the pruritus. Very, very easily is that. Pruritus and inflammation. So if you block this signal that will, otherwise provoke this synthesis and the action of all the pro-inflammatory cytokine, if you block this signal, you block pruritus and allergy. It's a very, very rapid action and very few side effects, and can both be used for acute flares. So you have a dog that is scratching for a few months, a year, or maybe it was okay and started scratching. It was okay on allergen-specific immunotherapy and it started scratching 1-2 weeks. So you have to keep under control these acute flares, but also for chronic long-term management. The dosage is nothing new, is what is written in its label. Lokivatmab is the newborn, is a canonized monoclonal anti-canine IL-31 antibody. IL-31, so interleukin-31, is the major interleukin involved in the pruritus in dog. So both oclacitinib, that blocks the the cascade or initiated by the interleukin-31, and the lokivatmab, that block the actual interleukin-31, block the pruritus. Lokivatmab is given as a subcutaneous injection. It should be given every 4 to 6 weeks to the dog, but actually it can be given when the dog starts to be scratching again. And is a very safe treatment also in the long term, and very effective treatment. And then, as I told you, you have to take care of the restoring barrier, of the skin barrier. You cannot think you're going to manage an atopic patient just giving oclacitinib or just doing lokivatmab. The majority of dogs need the owner to take care of their skin and of the hair coat. And in this way, you will have much more success in the chronic and long-term management. How can we do that? With the use of topical moisturizers and shampoos that should be done every week, every 2 weeks, depending, this is depending lots of factors, the size of the dog, the willingness of the owner, the collaboration of the dog itself. But you should use, and there are lots of products on the market, products that contain lipids like cholesterol and essential fatty acid, complex sugar that helps in keeping under control secondary infection, ceramide and other antiseptics, and then you should give essential fatty acids, which are very important in keep this epidermal barrier healthy and safe. Essential fatty acid can be given both topical or by mouth. Omega-3 especially, but alone or together with omega-6 are the main essential fatty acid given in canine atopic dermatitis. And in this chronic patient, you should do, I don't know, 2 months of administration, 1 month of pause, and so on, all year long in order to improve pruritus and skin barrier. So let's go now to the end. Let's see what we've done with Asia. We have resolved hair secondary infection by the use of a shampoo containing miconazole and chlorhexidine, both at 2% of concentration, once a day in the axillary region until the bacterial infection was cleared up. And then again, we've used the same topical ear product, this time for the left ears, twice a day for 14 days. And then we plan the recheck in order to see if the secondary infections are under control and we can stop the treatment for them. In the long term, we've proposed allergy testing and allergen-specific immunotherapy, but the owner didn't want to go ahead for that. So we decided, together with the owner, to keep Asia pruritus under control with long-term treatment with oclacitinib. We left, as I told you, free treatment monthly, forever, all year long. We gave her essential fatty acid by mouth all year long, repeating cycle of 2 months, followed by 1 to 2 months of pause. We gave the owner a moisturizer shampoo to be done every 2 to 3 weeks, depending, on the period. And we planned to recheck Asia every 4 to 6 months until needed differently. Of course, if Asia was going to have a relapse in the pruritus, we were going to check her more regularly. Okay, so this is what we've done with our patient that can be very similar to what you can do with also your patients. And this was the end of my presentation. I hope you enjoyed, and I hope you've learned few or many things from this talk. And hopefully your approach to the pruritic patient will be less frightened from now on. Thank you very much. Now we see if there are questions.
Okay, thank you very much, Dr. Dedola, for a very interesting lecture. And I would like to invite our audience to ask their questions. So please type your questions in the chat. Now I can see a question which came a few minutes ago. It's about ruling out leishmaniasis. So how can we rule out leishmaniasis?
Okay, so in this case, we didn't really need to do any other test because the dog has improved on treatment that won't be helpful in course of leishmaniasis. So obviously, if Asia wouldn't have improved with the oclacitinib and the treatment for secondary infection, we would have gone further and looked for leishmaniasis in this dog. And the further tests you can be doing can be, PCR on bone marrow, or, maybe some other molecular testing, maybe skin biopsy and immunohistochemistry on the skin. But in this case, because we have an improvement with treatment for allergy, we didn't feel we needed to go further to rule this out.
Okay, we have another question, which is, I think you have already covered this, which is how we restore the skin barrier. Maya asked this before you explained. I think you went through this very extensively.
Yeah.
And we have another question, which is, what about hormonal diseases? Do you look for some hormonal diseases in your differential diagnosis?
Well, usually hormonal diseases are not itchy. They don't cause pruritus in dog unless they have secondary infection. You look for hormonal disease if you have clinical signs that are suggestive for them. So, you know, in case of hypothyroidism, for example, you can have the dog that is bradycardic or feel cold, maybe has got a bilateral non-inflammatory alopecia of the trunk, then you can start thinking about a possible hormonal disease. But if the dog clinically look perfectly normal, the blood exam are normal, there's no reason of thinking about hormonal diseases.
Okay, now we have another question, which is about the advice that you give to the owners to wash the dogs. So for how long, how many times per week?
Okay.
So what are the instructions that you're giving?
So this is a very good question, and actually give me the opportunity of make clear some of the concepts. So one important concept is that the washing of the dog shouldn't be very aggressive, especially short-coated dog shouldn't be washed very aggressively against the growth of the hair coat, because this can actually cause sometimes folliculitis. For what concerns the frequency of bathing, if you use the product I suggest use, you know, with this ingredient, very good ingredient with lipid, essential fatty acids, ceramides that are not aggressive, you can actually use them as much as you want. The principle is that if you use the right product for the right patient, you then have issue on how often you should wash the dog. The problem starts when you don't use the right product for this patient. Then you advise the owner, if they see that the dog is itchy or is red after the washing, you can try to change shampoo. But if you use, you know, this delicate product with this ingredient, you don't have any problem, even if you wash the dog weekly or every 3 days.
Okay, we have some questions which concern the food. So one question is, if you have no hydrolyzed protein available, what can you do?
This is, if you don't have hydrolyzed protein, you can choose the homemade diet, which is always possibilities. For what concern the you know, single protein commercial diet, there are unfortunately lots of studies that are demonstrating that they are contaminated by other protein. So they are not actually the best diet to be used when you are doing an hypoallergenic trial. So really, if you don't have hydrolyzed protein available, you should go for the home cooked diet, choosing for a new protein and a new carbohydrate source.
We have another question along the same lines, which is, when you have to choose a hypoallergenic diet, do you prefer a dry or a wet food? And is it true that dogs may be allergic to the dry food, which I think is partially what you've already answered?
Yeah, no, there's no demonstration that the dog are allergic to dry food. There is some, you know, question about the possibilities that dog allergic to house dust mite might react to dry food, because in dry food, it is possible to find storage mites that you obviously don't find in the wet food. But this is not related to the food allergy itself. It's more related to the environmental allergy.
Okay. Now, somebody else, Sarah, is asking, the presence of otitis can make us think that this is an allergic problem, or it might be Sarcoptes.
Okay, the otitis externa is very often and actually nearly always, associated with allergic dermatitis. So Sarcoptic mange mainly caused desquamation and exfoliative dermatitis of the ear pinna, but it can happen also during the Sarcoptic mange. By the continuous scratching of the dog, you can have an irritation of the external ear canal that can cause otitis. So obviously, even if otitis is much more suggestive for an allergic reaction or for an otodectic mange, which is actually a mite that lives in the ear canal, also in Sarcoptic, the dog with Sarcoptic mange, you can have otitis as a secondary problem.
Okay, we have a question about the dose of corticosteroids that you would use in a true atopic dermatitis. So what is the antipruritic dose?
The common anti-inflammatory dose is, it goes from 0.5 to 1 milligram per kilogram once daily. It is usually not necessary to go beyond this dosage, and it is usually suggested not to use retard or deposit steroids. You should always use the non-deposit steroids with the dosage to be given daily until remission of the pruritus, and then going and withdrawing gradually the dosage.
Okay, so we are running out of time, so I suggest that you take one or two more questions.
Okay.
So we have a question which is about Asia. So this case, if Asia comes back earlier with worsening of pruritus while she is on Apoquel, what do you use to stop the itching?
Well, let's say that this would be a very rare situation, but if it happens, you can associate the administration of lokivetmab, oclacitinib and lokivetmab can be given easily together, or you can use steroids or cyclosporine. I mean, Apoquel is oclacitinib can be given with any other treatment for pruritus with no problem at all. My first choice usually is to do lokivetmab associated with oclacitinib if I have a dog that is refractory to the treatment with oclacitinib. But I would like to say, just to do a bit of brainstorming again, that if I have a dog that is coming back with pruritus while on oclacitinib, the first things I do is to try to think if there can be something else that is causing pruritus, because it's very, very rare that the dogs are not, responding to the administration of oclacitinib. So first of all, revise your diagnostic workup, and then if you are really sure this dog is atopic, add another treatment for the pruritus. Just don't go blinded and think, okay, Apoquel is not working, oclacitinib is not working, I have to do more treatment for pruritus.
So, do you recommend immunotherapy for most atopic cases? And what percentage of dogs on immunotherapy do significantly better?
Okay, I usually proposed in allergen-specific immunotherapy. Of course, there are some cases in which I feel, based on what is said in the literature and from personal experience, that will respond better than other, but I always give it a try, and my feeling is specular to what is written in the literature. So we approximately have between 50 to 60% of dogs that get better with allergen-specific immunotherapy.
Okay, Dr. Dedula, thank you very, very much. We really run over time, so we have to close this webinar. I would like to thank you for accepting our invitation to lecture and for your very, very interesting lecture this evening. I would like to thank all our participants. I hope that we see you very soon in one of our next webinars. So goodbye to everyone, and enjoy the rest of the evening.
Thank you, and thank you very much as well from my part, and enjoy the evening as well for me.